Hello friends, today we will be discussing about paragangliomas. Now as the name implies, paragangliomas, they are the tumors of paraganglia. Now what are paraganglia? Basically paraganglia, they are clusters of neuroendocrine cells dispersed throughout the bodies. Now these clusters, they are closely related to autonomic nervous system. So they can be parasympathetic or sympathetic. Now the largest cluster of these cells, which are also called glomus cells, these are found within the adrenal medulla. Now other smaller clusters, they are located elsewhere in the body, where in the abdomen, thorax and head neck regions. Now the tumor arising from these clusters or paraganglia or glomus cells, they are called paragangliomas. Now all of you must have heard about the terms glomus tumor, glomus jugulare or carotid body tumors or pheochromocytomas. But many of you might not be knowing that these all tumors are related to one another, and we will be discussing about how they are related to one another. Now, so as I have already told you that paragangliomas, they are rare neuroendocrine tumors arising from paraganglia. So because they are autonomic nervous system related, so they can be divided into parasympathetic paragangliomas or sympathetic paragangliomas. Now the tumors arising above the thoracic inlet, that is in the head neck regions, they are basically parasympathetic paragangliomas. The tumors below the level of thoracic inlet, that is in the thorax or the abdominal cavity, they will be called as sympathetic paragangliomas. Now parasympathetic paragangliomas, they all have one common thing, that they are non-secretory. They don't secrete catecholamines. So how will be they presenting in the patient? They will be presenting as mass or according to their mass effect. Now depending upon the location, head neck paragangliomas or parasympathetic paragangliomas, they are divided into carotid body tumors or chemodectoma. Second, jugulotympanic paragangliomas or glomus jugulare and glomus tympanicum. Third, vagal paragangliomas or glomus vagale. Now coming on to sympathetic paragangliomas. As the name implies, they are sympathetic and they will be secreting catecholamines. So the patient will be presenting early and will be presenting with headache, palpitation or hypertension. I already told you they are present below the level of the neck, so their sites will be abdomen and thorax. Now the largest cluster I already told you that is present in the adrenal gland. So they are present in the adrenal medulla. So the most common location for the intra-abdominal paraganglioma is the adrenal medulla, and that is called pheochromocytoma. And other extra-adrenal sites will be along the organ of Zucker-Kendall. Other site is urinary bladder base. Third site is thorax or mediastinal paragangliomas. Fourth site is paravertebral. So coming back, paragangliomas, they are parasympathetic or sympathetic. Parasympathetic, they are above the level of the thoracic inlet. Sympathetic, below the level of thoracic inlet. And parasympathetic, they are divided into carotid body tumors, jugulotympanic paragangliomas, glomus vagale. And sympathetic, they are divided into extraadrenal organ of Zucker-Kendall, bladder base, thorax, paravertebral or intraadrenal or pheochromocytomas. Now we will be discussing about the parasympathetic paragangliomas, that is in the head and neck region. One common thing about paraganglioma is that they share the pathology, the radiology and the other clinical features, except for their mass effect or the catecholamine secretion. Now coming on to their pathology, all paragangliomas, they consist of two types of cells, that is type 1 and type 2 cells. Type 1 cells, they are also known as chief cells. Type 2 cells, they are also called as sustentacular cells. The common pathology is that they form clusters or lobules of chief cells, which are called zelbelen. Now let's see how the zelbelen looks. This is a cluster of chief cells, that is type 1 cells. They are surrounded by type 2 cells at the periphery, which are also called sustentacular cells. And now all these clusters, one cluster, other cluster, other cluster, other cluster, these all are separated from each other by the fibrovascular core. Now these fibrovascular stroma separating the clusters, and this is the main pathology of all paragangliomas. These clusters are called zelbelen, consists of central type 1 cells, peripheral type 2 cells or sustentacular cells separated by fibrovascular stroma. Now coming on to their malignancy, how the malignancy is defined. Now all of you know that in thyroid the malignancy is defined by the invasion of the capsule or the vessels, but in case of paragangliomas the invasion of capsule or the invasion of vessels, that is not the defining feature of malignancy. For malignancy there must be evidence of metastasis. Only metastasis will define malignancy. No capsular invasion or vascular invasion will define malignancy. They can also be present in benign diseases. So they all are paragangliomas, but as you know in the pheochromocytomas you must have read that they are governed by rule of 10. Now in case of these paragangliomas rule of 10 also applies. So the rule of 10 is 10% are malignant, 10% are extra-adrenal, 10% are bilateral, 10% are familial. So next coming on to immunohistochemistry. So as already told, type 1 cells, type 2 cells. Type 1 cells will stain for neuron specific enolase, chromogranin A, synaptophysin. Synaptophysin means synapses. Synapses for neurotransmitter because they are autonomic nervous system. So neuron specific enolase, chromogranin A, synaptophysin. These are the stains for chief cells. Now second type of cells, sustentacular cells, they will stain for S100. S for sustentacular, S100. And now coming on to the most common genetic mutation in paragangliomas, succinate dehydrogenase subunit. Succinate dehydrogenase subunit is the most common genetic mutation. SDHB, SDHC, SDHD. The most common genetic or familial diseases in which the paragangliomas are common. So first is phacomatosis. What is phacomatosis? Phacomatosis, they are neuro-oculocutaneous syndromes. Most common of these syndromes are VHL, von Hippel-Lindau disease, tuberous sclerosis, Sturge-Weber syndrome and neurofibromatosis type 1. Second familial disease is MEN type 2. Third type of familial disease is Carnage triad. Now Carnage triad or Carnage syndrome, this consists of 3 diseases. Most common of them are pulmonary chondroma, GIST, gastrointestinal stromal tumors and extra-adrenal paragangliomas. You can remember Carnage triad as CGP, chondromas, GIST and paragangliomas. Now coming on to their radiology. As they are paragangliomas, I have already told you they will be sharing their features. Radiological features are also shared by them. Most common appearance on MRI will be salt and pepper appearance and light bulb appearance. We will be coming on to the MRI later on. Now coming on to the head and neck paragangliomas, we will be today discussing about the carotid body tumors. Carotid body tumors, they are the most common location of head and neck paragangliomas. Second most common location is glomus tympanicum. Third is glomus jugulare. Fourth is glomus vagale. They all are situated along the branches of glossopharyngeal and vagal nerves. Coming to carotid body tumors, they are also known as chemodectomas. Chemo here implies chemoreceptors. And now these are rare benign tumors arising from carotid body at the bifurcation of common carotid artery. The location of carotid body tumor is bifurcation of common carotid artery. What is the function of carotid body? The function of carotid body is regulation of pH, because it is regulating the pH of the body. Now the persons living at higher altitudes, they will be having some kind of chronic hypoxia, and because of that chronic hypoxia, carotid body hyperplasia will be there, and over the years these persons will be developing carotid body tumors which develops from chronic hypoxia. So chronic hypoxia leads to carotid body tumors in patients living in higher altitudes. The clinical feature will be, it is a slow growing tumor, so the patient will be presenting late. So the patient will be an elderly patient having long history of painless, slow growing swelling for last many years. As the swelling is located at the bifurcation of common carotid artery, so it is located in anterior triangle of the neck. The carotid body is situated in the carotid sheath. Carotid sheath is encasing the carotid vessels. So the swelling will be laterally mobile but vertically fixed. It is laterally mobile but vertically fixed. Now the presenting feature will be a painless, slow growing mass which is oval, firm, vertically placed, laterally mobile. So that is called classical potato tumor because it is a lobulated, firm, vertically placed tumor. Now the other content of the carotid sheath is the 10th nerve. The mass effect of the mass will be Horner syndrome and unilateral vocal cord paralysis. What is Horner syndrome? It is meiosis, ptosis, anhidrosis and anophthalmos. Unilateral vocal cord paralysis because of recurrent laryngeal nerve. Now the pressure on the tumor will give rise to syncopal attack because it is closely related to carotid vessels. Other will be, as the vessels are closely related to the mass, when you palpate the mass there will be transmitted pulses. Because the mass is highly vascular, so biopsy is contraindicated. So the chemodectomas, carotid body tumors, elderly patient, slow growing swelling and located in anterior triangle of the neck, laterally mobile, vertically fixed, classical potato tumor. Now for a patient presenting with a neck mass, investigation of choice is always MRI. Any patient with any neck mass, IOC is MRI. And now we have done MRI. There is a mass in the neck which is closely related to the carotid vessels. So what will be the next investigation? Next investigation of choice will be MR angio or CT angio. These are non-invasive methods of investigation. The third method of investigation will be digital subtraction angiography, which is a invasive method, but it is the most definitive diagnosis can be given by angiography because the biopsy is contraindicated. How will you reach the diagnosis? So the diagnosis is reached by angiography. This is an invasive method, so it is used after non-invasive MR angio or CT angio. On MRI, this is a MRI axial section of the neck. Why this is MRI? Because the bones are not very well visualized. This is vertebral body which is not very well visualized. I told you that on MRI there is a light bulb appearance. Why there is light bulb appearance? The mass is very bright on MRI and it looks like a light bulb. Here this is the normal side where there is no mass. This is a mass, large mass which is appearing very bright, so giving light bulb appearance. The mass is very vascular. The vessels, they are not shown up on the MRI. They appear as flow voids. These serpentine lines, these are vascular flow voids. So this gives you the salt and pepper appearance. But why salt and pepper appearance? Salt is white, pepper is black. So the whole mass is white and the vascular flow void give them salt and pepper appearance. So MRI, you have done the MRI and there is a neck mass. After this you will go for MR angio or CT angio, that is non-invasive. What is the sign on the CT angio or MR angio? That is called lyre's sign. This is lyre. This is a musical instrument. And why this is lyre sign? Because there is a large mass which is causing splaying of internal carotid and external carotid artery. This is common carotid artery giving rise to internal and external carotid arteries. There is a large mass situated at the bifurcation of common carotid artery causing splaying of internal and external carotid artery giving rise to lyre's sign. Okay. Now you have done CT or MRI and you have thought that some chemodectoma is there. How will you reach definitive diagnosis? Because you can't do biopsy because it's a vascular mass, you will do digital subtraction angiography. Digital subtraction angiography, that is DSA, that is an invasive procedure. What will it show? It will again show the anatomy and the location of the tumor. Common carotid dividing into internal and external carotid arteries splayed by a large mass giving lyre's sign. Okay. Now pathology, I have already told you the cell type 1 cell, type 2 cells, clusters of Zellbellen and the sustentacular cells and the fibrovascular stroma. Coming on to treatment part. So what will be the treatment? treatment is surgical excision. Patient is an elderly patient presenting with a neck mass, and the treatment of choice is a excision. And if the tumor is small, you can do surgical excision. But if the tumor is very large, there is high risk of vascular injury. If the vascular injury to internal carotid artery is there, the patient can have infarcts, ischemia, patient will have paralysis. Presenting with a neck mass and we have operated the patient and the patient will having paralysis. So the tumors which are very large, they have high risk of operative complications. What will you do if there is a large mass? We will do digital subtraction angiography and embolizing the feeding vessel. Embolizing the feeding vessel by coils. The feeding vessel will be blocked. The tumor will undergo necrosis and will shrink in size. Then we will operate it. So in large masses, we will be doing feeding vessel embolization with the help of DSA. And again, the tumor we have operated, there are recurrent masses, there are residual masses, or because of very large size or the elderly frail patient, the tumor is completely inoperable. So what will we be doing? We will be giving the patients a radiotherapy. Radiotherapy will not be curing the tumor. It will only be stopping the tumor from growing. So it is a tumor static, not tumor curing. So in the treatment, smaller tumors, excision, larger tumors, feeding vessel embolization, and then making the tumors small and then excising it, and in large inoperable cases, radiotherapy or recurrent or residual tumor.